Thank you, Megan, for the introduction. I appreciate it. So I'm going to talk today about the AI, of course, and how it's transforming clinical practice in ED specifically. I mean, since AI started almost two years ago, when ChatGPT was around, everybody was introduced to AI, although it existed before that. But this transformed how we think and practice every day. So why AI, and why I'm talking about AI, or why in ED specifically? So you have to know, I mean, of course, we all know that the ED visits increased by 12% globally in the last few years, putting pressure on EDs, leading to patient unsatisfaction, long patient stays in ED, and also we have to know that every ED encounter we see with a patient generates around 1 gigabyte of data, including electronic records, images, CTs, ECGs, all that. And it's a lot of data that we should invest and learn from using AI. So this leads to a lot of information overload and missing diagnostic test results. A lot of studies have shown that doctors have missed diagnostic test results because there's a lot of information there. So how can AI improve the ED workflow? Just to remind ourselves of how ED workflow is. Of course, there's a period before the patient arrives, whether that's from home or from the GP or from ambulance, and then goes to the triage in the ED, and then being diagnosed by a clinician, and then goes to management, whatever disease he has, and then disposition, either home or admission. And then there's element of documentation, of course. So if we talk about the pre-arrival stage, there's a lot of AI stuff has been being developed, specifically the forecasting or the prediction of patient volume. And if an ED like director knows every day how many patients he's expecting on the lowest and highest days as well, this would be very useful to allocate staff and medical resources. And there's a very interesting studies been done before, and this was using the weekday, the month, even the weather, temperature, is it raining or not, is it sunny or not, to predict daily patients' arrival in ED, which is very interesting and can help allocate more staff, as I say. Also, machine learning can be very useful in emergency setting to predict triage the patients into high risk, low risk, or medium risk based on their past medical history and presenting complaint and maybe the initial observations of vital signs. And this was done before as well. They use vital signs, age, sex, day of the week, time of the visit, how they came to the hospital. Is it like through ambulance or GP referral or walk-in? And calculate 2-day mortality prediction. It was successful. Also, triaging system can be done to predict the number of inpatient admissions. Say you can easily predict with a lot of variables like triage information, symptoms, observations, how the patient came to the ED, to predict if the patient will be admitted or not. So triaging is very helpful, and this has been used in multiple studies over the last few years. Also, there's a lot of patients who get bored of waiting and they leave ED without being seen. And you can detect these patients, even predict them from the beginning based on sex, age, triaging, have their low risk or medium risk or high risk, the time of the day of the week, and how much they're waiting. And you can predict which patient will leave ED. So all that, if it's like imagine it as an electronic dashboard in front of whoever is managing ED, will have a lot of information to decide. A lot of management decision can help control the allocation of resources and so on. So if we talked about the pre-arrival and we talked about triaging, we can talk about diagnosis as well. So especially in imaging, because imaging, if you imagine an ED, it takes a lot of time to send the patient to CT or X-ray or do ECG. It takes time. So if you do AI, will not replace doctors, but can easily make things faster. So, for example, it can be integrated in CT to detect intracranial hemorrhage quicker, and this reduce the time for CT reports, which reduce their patient ED stay. Also, AI can be helpful to draft reports for X-ray, which can be reviewed later by radiologists. And they've done many studies that AI and radiologist reports were not statistically different, means that AI can reach the same diagnosis in quicker time, and this saves time. Of course, it has to be reviewed by radiologists, but this can save time for the patient in ED, which the less time patients stay in ED will be better for everybody working ED, right? And then, of course, there can be CT integration for detection of PE, and like again, using deep learning, deep neural networks can easily detect CT. So it's all like the diagnosis can really make it fast in terms of imaging based stuff. Okay. Also for ECG, it can detect occlusive MI, and even this makes it faster for the patient to be triaged to, let's say, the cath lab, or quicker before even being like evaluated formally by a clinician while waiting. And this has been done before as well. Also, it could be useful in ultrasound. Ultrasound is an essential tool in ED right now, right? And like Dr. Sarah was talking about the echo and use of ED, and there's a lot of uses there, lung ultrasound, abdominal ultrasound, and all that. So currently, there is no AI assisted guidance like in real time that's validated yet. But if this develops, will be great. So imagine you put your probe on the patient, and then it guides you where to put it, and a real-time interpretation can help you a lot and save time, because you don't have to send the patient to seek right away, and any emergency conditions can be diagnosed quickly. So I mean, it sounds crazy currently, but it's the future. Also, it can predict sepsis. There's a lot of studies about integrating variables from the patient observations or vital signs with lab and even the patient documentation, the patient notes that the doctor write, and this can detect sepsis 4 hours earlier than it happens, which is awesome, really. If you know this patient is high risk for sepsis, maybe you'll have a look at his observations more close. Maybe you do procalcitonin, maybe start and break antibiotics if you have low threshold for it. So it is helpful to do in real practice. Regarding management, there's a lot of also AI can be helpful, and there's a particular study that AI was able to predict major cardiac events 30 days before happening for patients presenting with chest pain. So you can predict this patient, for example, will be high risk, so can be referred to cardiologist earlier, or be reviewed by a cardiologist earlier, and maybe this patient is very low risk for major cardiac events in 30 days. So it can be referred to a GP, or maybe has a follow-up in a longer time. And this is very helpful in allocating resources in ED as well. So this particular study used 14 clinical variables from the electronic medical records to predict 1 month mortality and also 1 month acute MI for patient presenting with chest pain in ED. So again, remember this triaging or the workflow in ED. There's a lot of stuff we can target. So pre-arrival, we can predict the patient volume on a particular day to help allocate staff and resources. For triaging, we can predict patients leaving ED, or prediction of admission, or prediction of high-risk patients, or prediction of sepsis even, and helping with diagnosing with imaging and ECG and ultrasound in the future. And management can predict cardiac events, which can help like triage patients to be referred to cardiologists early or later. Also for documentation, AI scribes is very important. So I'm sure you heard about this. There's a lot of AI softwares that can hear the encounter between the doctor and the patient and write it, or even look at the previous notes and arrange a discharge summary that has to be reviewed by a doctor. So it is very useful, and this decreases time. So everything in ED, because it's very time critical, decreasing time in any single point or improving predictions is very useful, because it's highly stressful environment. So in practice, if you want to implement AI in wherever you work, you have to identify a problem, like let's say prediction of sepsis or number of patients in ED or whatever, and or we call it a pain point. Something is painful that you need to help your department with. Then you collect data all the input variables and the outcome that you want to help with. And then you build a machine learning model or deep learning model or AI model, which basically you get all the data that you collect. Let's say you collected 1,000 patient data. You split it into 80% for training, for a training set, and 20% for a testing set. We mean by that you teach the model or train the model on the data you collected from 80% of your patients. If you're talking about 1,000 patients, you can train on 800 patients, and then you test it in the 20% which the model didn't see, and then you do what we call model evaluation. You evaluate the model and see its accuracy. It's like 80% or 90% or whatever, and then you start implementing it in the workflow of ED, either to the electronic system or like a separate app or whatever. And then, of course, it has to have a human oversight to see if this is really going in the right direction or not. We cannot just rely on AI totally. We have to put, it's an assistive tool, but it's not a replacing for doctors, right? And then we have to do a continuous monitoring for those models, because after a while the data can change, the patient behavior can change, the new therapies or even any other factors. So we have to do continuous monitoring and start collecting new data after a while and do the same stages again. But we have to be sure that there's a lot of challenges while we're implementing AI frameworks. The first one is bias in training model. Let's say we developed a model based on patients living in India. It would be really hard to take it and just apply it to patients in the UK or in the US and vice versa. So we have to, maybe you can take it and retrain it on patients, right? At the time in a different setting and reevaluate it from the beginning, but don't take it for as assumed. Also, for regulations, there's a lot of regulations being in process. It's not really clear or set up that we know that regulations can affect the implementation and approval of government to approve those protocols and those models we build. Also, data privacy is an issue, because you have to collect data which has a lot of ethical implications, and to make sure you maintain data privacy. So it's a lot of challenges, really. It seems easy, but it's not as easy. Also, the take-home message here would be that AI could be useful in time-critical ED workflows, which is really important in ED. AI should be clinician-centered, means clinicians should be responsible to develop it and maintain it and have oversight on it. And that's why there's a lot of clinical governance should be included, and that AI literacy is a must now. It's a core competency for clinicians. Every clinician should understand what AI means and how it can be used to improve his work setting and how to evaluate it as well. It's a must in this world, because it's gonna be it's happening. It's in the future. So that's my presentation. What questions do you have?
Thank you, Mortagy. There are a few questions, actually. We've probably got time for a couple.
Sure.
So the first one is, are there any recommendation for some types of AI applications? So are there any specific ones, or is it the kind of...
Yeah, so currently there's no like a big ChatGPT for doctors, for example. So I think every institution has to develop its own app or own AI workflow at the moment, because we don't have a big foundation model that can be used. We're not there yet. So it has to be developed locally, I think, for every hospital. However, if you develop something for CT, for example, because CT is the same wherever you go, maybe can be useful. But again, there's no unifying a model that can be used everywhere at the same time now.
Thank you. I suppose that's probably something that will come in the future. One of the earlier questions was that obviously if AI is so good at interpreting X-rays, why does it then need a radiologist secondary review?
Exactly. So part of it is that we don't trust AI as much as clinicians. It's not that the AI is not good. And part of it is legal. So legally, AI cannot sign the report. We don't have such regulation at the moment. It has to be signed by a radiologist or someone with like a radiology clinician. And for this to change, regulations has to change. government has to do something different. But at the moment, we can't. Legally, we can't. Even if AI is better than doctor, we cannot do it because it's not legal. It's just an assistive tool. Like when you calculate your CHAT-VASC score, for example, it doesn't replace you as a doctor. You have to think about it and even think about benefits and risk, and maybe you can go against it. It's the same thing. It's just a tool. It does not replace doctors yet. I mean, I don't think it will at any point.